Hello everybody and welcome to another tutorial. I'm James Piper, Clinical Teaching Fellow at the Royal Free. This is another tutorial for the acute medicine students year 4 of the MBBS programme at University College of London. As always, if you have any questions or comments, you can email them to me at james.piper@ucl.ac.uk. And for those of you that are following the tutorial program in real time, I wish you all a happy Easter and Passover, and that you've all had, as good as you can in these circumstances, a good bank holiday. And also for those who are following me in real time, I am going to take a few days off myself before I go back on night duty. So this will probably be my last tutorial for a week or so. So what are we going to talk about in this tutorial? Just to say that this covers one of your core conditions in acute medicine as per your curriculum. So what are we going to try and do in this tutorial? We're going to understand the basic physiology of acute pain, going to familiarise with the analgesic ladder. We're going to talk a little bit about the different groups of analgesics, including paracetamol, non-steroidal anti-inflammatory drugs, opioids, the role of antiemetics, and the assessment of pain in oncology patients. So it probably goes without saying in a statement of the obvious, but of course pain is a common association with acute illness, and pain of course will present in a variety of forms. Some of it will be quite dramatic, such as say the amputation of a limb. Some of it will be chronic and not necessarily part of the presenting problem. So a good example of this is a patient who has COPD, who's been taking multiple courses of steroids, who in turn has got osteoporotic bone fractures and has chronic back pain as a consequence, which may be exacerbated by coughing, which of course will be part of their acute presentation. So pain does often form part of patients' presentations, whether directly or indirectly. And of course our job, and your soon to be job as medics, will be about relieving suffering. So pain assessment should form part of your clerking, the assessment and management plans. Now pain is a very difficult thing to describe, and one of the things that I have got into a good habit of doing is asking patients in their own words to describe the pain, and I often write those down. They can be quite a powerful tool and also show to the patient that you're listening to them and you are focusing on what it is that they are saying. Now, when we describe pain, pain can be perceived in a number of ways. So you can perceive or assess pain in an objective manner. So for example, I'm going to show you a pain score at the moment, and you can say to your patient on a pain scale, say 0 to no pain, 10 being the worst pain you can ever think of, where do you sit on that scale, versus 2 subjective. So this might be, it's a sharp pain, it's a niggle, generalizing, odd pain, it's a nip. Patients will often have a variety of colloquialisms to describe their pain, and it's important that you make sure that you understand what that colloquialism means. So for example, I worked in Liverpool for a little while, and you can imagine some of the dialect is a little bit different. There were some interesting words that you had to make sure you understood to make sure that you were taking a patient seriously and ascribing the right severity to the terms that they would use. Then there is visible versus hidden pain. So what do I mean by that? So visible pain, so a patient who breaks their ankle, they get a plaster cast, and people can see that and people can easily respond to it because it's a visible, objective measure of pain, although it doesn't necessarily tell you how much pain the patient is in. Then there is hidden pain. So this can be, for example, from compartment syndrome, internal pain, so through appendicitis, for example, generalized pain through bowel ischemia, and so on. Pain that we tend to deal with in the emergency department and the acute take is often acute pain, although there are a lot of patients who will come in with chronic pain. And so pain is what the patient says it is, but it is important to take into account multiple factors. So what do I mean by that? So often their current sort of psychosocial well-being, financial well-being, any kind of triggers that have brought them into hospital, what was the history of the presenting problem, and so on. So I've put together a little summary chart of the different scales that you might have. So as you can imagine, asking a child to describe their pain succinctly is probably going to be quite tricky if they can speak at all and have developed the vocabulary to describe their pain. So the top row gives you an example of a pediatric type scale, although it's a little exaggerated, you can see the point. So obviously patients such as children who are sitting comfortably, eating, interactive, smiling, bubbly, are probably not in as much pain as children who are unbearable or kind of excruciating, unable to vocalize, or very, very somnolent with acute illness. So on a sort of number rating scale, you can say to your patient, well, pain at 0 is pain-free, and 10 is sort of unimaginable, unspeakable, and you can sort of pick your descriptive term. But you can see that when you categorize it into sort of no, minor, moderate, and severe, so examples of obviously no pain, patient describes feeling perfectly normal. Minor pain might be nagging, irritation, annoying, but it doesn't interfere with most daily living activities. And again, so when you're performing your functional assessments in your clerkings, you should be considering any pain issues that the patient might have. And this is quite important. So for example, when we are making ceiling of treatment or limitation decisions, it's important to understand what it is that's limiting the patient. So if, for example, if it's chest pain or significant peripheral vascular disease that's keeping them housebound, then obviously that's one thing. If they are housebound because they have severe osteoporosis or osteoarthritis and they're waiting a hip replacement and they should be able to mobilize afterwards, well, that's a very, very different level of disability or sort of entrapment, if you like, that is comparable to other things. Moderate pain interferes significantly with daily living activities. It requires lifestyle changes, but the patient remains relatively independent. Severe pain, however, is disabling. They are unable to perform daily living activities, engage in normal activities. Patient is disabled, not a particular term I like using, and is unable to function independently. And some examples of this are all across the internet. This one comes from palliativecare.org.au. So what are the adverse physical effects of pain? So the stress and anxiety of pain or painful stimulus can cause tachycardia, hypertension, and increased myocardial oxygen demand. And this particular aspect is important because if you have ischemic heart disease and you are increasing demand on the heart, you're going to worsen angina pain and then precipitate other medical problems. Patient may feel nauseous, they may feel vomiting, they may have ileus, and this is particularly important in patients who have had abdominal surgery or have acute abdominal pathology. It might be that they don't want to defecate, they don't want to pass gas, and so they will hold on to their bowel movements and therefore develop ileus on top of their opioid medication. If another example, if had thoracic or abdominal surgery, then they may have a reduced vital capacity. They're going to have difficulty coughing if they're in pain. And again, they're going to hold on to their secretions, causing basal atelectasis and an increased risk of community or hospital-acquired pneumonias. And this is a reason, for example, for those of you that are trauma hawks, this is a reason that why we have started to more aggressively fix rib fractures as part of our trauma team, because not fixing the rib fractures leads to significant pain and therefore significant sequelae, as outlined on the slide. Urinary retention and also venous thromboembolism from immobility. What are the non-physical effects of pain? And it's important that you give these equal weighting. Again, these are subjective, but it's important that you don't ignore them. What I think is what makes an attribute of an excellent doctor is someone who can be sort of kind and empathetic to a patient and take into account their views on the non-physical aspects or burden of any illness or presentation. So it might be that it's causing physical distress. So for example, if it is that unfortunately someone has lost their leg in a road traffic accident, obviously that's going to cause significant distress. It might be that if your leg, let's say, is fractured and you're in a plaster cast, and as you can probably know, they can get itchy. You're going to have to sleep in a certain position. As I said, for those of you that have been to PFP, you'll know that I broke my arms some years ago, and as you can imagine, I had to sleep with both of my arms on pillows, always had to sleep on my back. It was terribly uncomfortable, and that's for at least 6 weeks. So my sleep was very much interfered, making me a little bit of a grumpy bugger. If we don't manage the pain, or at least seem to take seriously the pain needs of a patient, it can cause harm to the healthcare profession to patient relationship, which in turn can lead to complaints. And it's important that we do everything that we can to avoid complaints. So easy examples I can think of when patients or families write in to complain, it might be that the patient was in pain, pressed the buzzer on the ward, and the patient perceived that it took a very long time for the patient to receive their analgesia. Remember, it's worth noting that opioids, for example, or Schedule II narcotics have to be signed out by 2 members of qualified nursing staff. So actually, if you're on a night shift and there's only 2 nursing staff, actually there can be a risk of significant delay in issuing the patient with the opioid analgesia. Other problems might be if that the physiotherapist wants to mobilize the patient and they are not adequately analgesed, then it may well be that obviously the physiotherapy session fails and the patients then perceive that they are failing to make progress in their recovery. If the patients are dealing with significant post-operative pain or post-insult pain, it might be that they have a prolonged hospital stay, therefore a delayed return to work. There may be a stress on interpersonal and even sexual relationships. And an example of that that's reasonably recent is the vaginal mesh scandal. And this is where potentially women had mesh implants in their pelvic floors, which caused significant pain, chronic pain, and dyspareunia, which is pain on having sex, which for some people can of course be a significant cause of comorbidity. So let's talk a little bit about now the physiology of acute pain. So to keep it nice and simple, nocioceptors are the sensory receptors for pain, and these exist in almost all tissues. The stimulus of pain are where the nerve endings are either damaged, so through trauma, or stimulated by chemical mediators. And essentially you have transmission of signals via afferent, which means towards sensory pathways of the central nervous system. And to keep things simple, you basically have 2 types of pain fibres. Ones are small myelinated A delta fibres which conduct fast pain, so this would be say from localised sharp pain, and larger unmyelinated C fibres which conduct slow pain, and this would be for example diffuse or dull pain. I've put up here the simplest form of pain pathway that I could find, and this is from www.teachmephysiology.com, and you can see here where you have the nocioceptors, which goes to the dorsal horns through the grey and white matter up through the second order neurons to the cortex and thalamus of the brain. So remember that your stimulation at the nociceptor could be mechanical, say from pressure, crush injury, fracture, thermal, burn, or sort of say chemical injury. It's also important to remember that there are obviously neurotransmitters which of course transmit the signal. Some of these are excitatory, such as glutamate and tachykinins. Others are GABA, for example, which is the most prominent inhibitory neurotransmitter. You can also have descending pain regulation from noradrenaline, serotonin, and opioid peptides. So when we think about the different groups of analgesics, of course, they all have different modes of action and different planes of action. So at transduction, so cold application, topical NSAIDs, obviously work at the peripheral nerves and so on. You can have drugs which will affect synaptic transmission, so local anesthetics, antiepileptics, opioids, peripheral and spinal blocks, and epidural and intrathecal analgesia. You can have medications that affect descending modulation. So for example, you've got antidepressants, opioids, cognitive behavioral treatment, and spinal cord stimulation. Then you have your perception of pain, and again, this is quite important that we were talking about earlier, for example, cognitive behavioral therapy. I just want to talk briefly about neuropathic pain, because although we don't in acute medicine deal with trauma, we do deal a lot with things like diabetic neuropathy, trigeminal neuralgia, and post-stroke pain. So neuropathic pain is initiated or caused by a primary lesion or dysfunction in the nervous system. It is commonly chronic. However, if a patient is having an acute episode, it may indeed trigger their chronic pain. So the neuropathic pain pathways are very different to those of acute pain. It seems that there are lower thresholds for activation of the injured primary afferents. So you've obviously heard of ectopic beats, and it seems that in chronic pain there are ectopic discharges of injured primary afferents, which will mean that patients are getting multiple extra pain signals that they otherwise wouldn't have. There are also sprouting of normal axons into the denervated areas. We also see evidence to suggest central sensitization and loss of inhibitory mechanisms, which will again mean that the patient's pain experience is exacerbated considerably. When we deal with the transition between acute and chronic pain, which for those of you that are interested in working in surgery is not an insignificant thing to think about, and that's why good perioperative pain management is so important. So it might be that you have initiating factors into acute pain, so it might be trauma, injury, infection, repetitive strain, or maladaptive behaviours. Now, it's important that when we think about pain and how we're going to manage it, we think holistically. So one of the protective factors, so these are things that will work in the patient's favour and decrease the risk of transition from acute to chronic pain, will be overall fitness, good sleep, emotional, positive emotions, good social support, sort of understanding and insight into their illness, protective environment, and so on. Risk factors, which will mean that they are more likely to develop chronic pain, are significant medical comorbidity, poor sleep, anxiety, anger, depression, societal conflict, abuse, stress, burnout, confusion, low mood, low resilience, and a chaotic, injury-prone and unsafe environment. Now, it's true to say that some of these are out of the hands of us at home, but it's important that you discuss all of these things when discussing pain, particularly if it's a complex patient. You'll often find that there's significant overlap between the physical and the psychological. So the sort of foundation, if you like, of prescribing and treating patients who are in pain is described by the World Health Organization Analgesia ladder. And as you can see that there are 3 steps. The first one is mild pain, where we will treat this with non-opioid with or without adjuvant analgesics. Mild to moderate pain in stage 2, opioid for mild to moderate pain plus non-opioid with or without adjuvant. And then step 3 would be opioid for moderate to severe plus non-opioid with or without adjuvant analgesic. And so basically the pain is persisting, you obviously move up the step, and as the patient's improving, you want to try and de-escalate. Another way of looking at this is the type of medications you use, and I've got a more simpler diagram towards the end of this talk. So for example, step 1 would be a regular paracetamol, step 2 would be something like tramadol or codeine, although I would strongly urge avoidance of tramadol. In fact, as a good rule of thumb, I haven't prescribed tramadol since I was in FY2, so that's going back some time now. Severe pain, or when I used to do my anesthetics, I'd obviously use things like fentanyl to help put the patient to sleep. What's important is that there is obviously regular administration of the analgesics. There's regular assessment using whatever tool you're going to use, such as a pain scale, and that's the one which we are most familiar with in hospitals. And then if you are struggling and getting towards step 3, that you consider specialist assessment and input from the acute pain team or my colleagues in anaesthesia. So I'm going to talk a little bit about paracetamol now. So it's a simple analgesic. Everyone uses paracetamol. The trouble is with paracetamol is that often it's underappreciated as an effective analgesia. And sometimes having this conversation with patients can be really tricky because they'll often want to dump the paracetamol and go on to stronger opioids or codeine, for example. And this is really something you want to try and avoid unless the patient is committed to taking regular analgesics such as paracetamol. One has to question that if they're not prepared to take paracetamol regularly, well, why is it that taking excess codeine or regular codeine will necessarily be any different? So I like to, where possible, make sure that my patients are committed to a basic analgesia regime before escalating it upwards. Now that's if you have the luxury of time and the patient isn't in a major pain state, or got a sort of post-operative pain or an acute trauma, for example. So paracetamol is a simple analgesic. It can be combined with other analgesics. It's a potent antipyretic, which is obviously topical at the moment and also quite good for those who have infections and so on. You can give paracetamol rectally, orally or IV, although it's worth noting that rectal administration of paracetamol has a suboptimal plasma concentration. It does reduce the opioid requirement, and this goes back to what I was saying earlier on in this slide about the importance of getting your patient to commit to at least taking regular paracetamol. The last thing we want is to increase the number of patients who are opioid dependent. Obviously, you can see the outcome of mass opioid dependency as is seen in the United States and some pockets of the United Kingdom. Couple of little fun numbers for you. So 1 gram of paracetamol has a number needed to treat of 3.8, but interestingly 1 gram of paracetamol and 60 milligrams of codeine has a number needed to treat of 2.2. Just as a little comparison, so IV paracetamol is as effective as ketorolac. Now, most of you won't have prescribed or used ketorolac before. This was something that I used to use in my anesthetics time when I used to do orthopedic surgery and so on. We'd use ketorolac. And that actually is interesting, has a number needed to treat of 1.8, which, or equivalent way of saying 50% of patients had over 50% analgesic relief by taking IV paracetamol. So it's important that you consider the use of IV paracetamol where appropriate. So what does paracetamol do? It's an inhibitor of prostaglandin synthesis. It's well absorbed from the small bowel, although it's worth noting that there is no demonstrable anti-inflammatory effect. So, for example, if you are concerned about pleurisy, for example, which causes inflammatory pain due to the rubbing of the lining of the pleura, paracetamol of its own accord is unlikely to help. You're going to need, say, paracetamol and ibuprofen and or diclofenac. There are very few side effects when taken at the standard dose. Occasionally patients will say that they are allergic to paracetamol. I've never yet seen a patient truly allergic to paracetamol, and that should caution you, and I appreciate I'm generalizing slightly, about whether the patient is seeking opioids or not. But if you are prescribing IV, then you do need to consider the weight of the patient. So, for example, certainly patients who are less than 50 kilos should only get 500 milligrams of IV paracetamol maximum. Remember, of course, although there are very few side effects when taken at a standard dose of 1 gram QDS, there is a significant risk of fulminant liver failure and need for transplantation in overdose. So compound analgesics, so these are analgesics are typically available over the counter. They are widely available. Most commonly is paracetamol and a weak opioid such as codeine. The type of combinations that you can get are 8 and 500, 30, 500, although 30 and 500 requires prescription. 8 and 10 milligrams over 500 milligrams of paracetamol do not. Gonadromol would be typically 10 milligrams of dihydrocodeine, which is stronger than codeine, and that's also over 500 milligrams of paracetamol per tablet. This will often improve compliance. There are synergistic effects, although it does make it a bit harder to disentangle what it is that's making the patient feel better and can restrict titration a little bit. Let's talk about non-steroidals now. So these are indicated for mild to moderate inflammatory pain. They have an antipyretic effect. They work by inhibiting the enzyme cyclooxygenase, which are multiple forms of these. You've probably heard of COX-1 and COX-2 type inhibitors. It's worth noting in terms of prescribing and contraindications that non-steroidals can increase the production of leukotrienes, and that's where sometimes there are concern about anti-inflammatories and asthma, as there is a risk of bronchospasm. Non-steroidals should be avoided in acute kidney injury and GI tract ulceration. They are well absorbed orally and most of the metabolism is hepatic, although you can give rectal suppositories of diclofenac, for example, and you can give ketorolac, for example, intravenously. Let's talk about opioids now. So basically opioids are formed from the interaction with opioid receptors to produce analgesia, and to keep it simple, their production is from the opiate from the opium poppy. The indications for opioids are severe pain, induction of analgesia, so for example you might use propofol and fentanyl, sedation, ET tube tolerance, so patients may have an infusion of remifentanil running whilst they have their ET tube in, and the aim of this is to keep them awake but to keep them what we describe as tube tolerant. In the palliative care, so for example codeine linctus or PRN oromorph can also be good for anti-tussive effects, and also can be quite good as a treatment for breathlessness, where you would use a small amount such as 1.25 to 2.5 milligrams PRN. Opioids can be classified in a number of ways according to chemical structure, activity at the opioid receptors, so pure agonists such as morphine and fentanyl, and a pure antagonist such as naloxone, which of course is a treatment for opioid toxicity. Or you can classify them via their duration of action, long methadone, medium morphine, and short fentanyl, for example. I would always suggest that when you're reviewing your pharmacology that you review the national guidelines such as NICE and the BNF for prescribing guidelines, or of course hopefully when we return back to normal we'll spend time doing prescribing. So just to talk about the effects of opioids, because these are important, as I say, it's at the very beginning, it's important to avoid a patient being in significant pain for a significant length of time. However, what you can't do and what you shouldn't do is ignore the side effects of opioids. Some, such as the CNS effects, include euphoria, hence their dependency, anxiolysis, sedation, nausea, meiosis. They can cause spasm of uretero-vesical sphincter, causing urinary retention. And I'll let you into a little secret about me. I had my tonsils out when I was a medical student. I think I was in my second year, and I had a general anaesthetic and had lots of morphine, so I had quite a difficult operation. And unfortunately, I went into urinary retention and had to have a lovely nurse put a catheter in. So it can happen to anyone. So renal effects are significant. Respiratory, you can cause dose-dependent respiratory depression, and as I said, the anti-tussive or cough effect. With gastric emptying, this can be delayed, decreased peristalsis and constipation, and this is important when you are thinking about treating patients or managing patients with overdose, about the need for airway protection and early reversal because of the high risk of aspiration. And unfortunately, this is often what we see in recreational drug opioid overdose, is that they often their airway isn't protected by the people that they are with, and they unfortunately develop aspiration pneumonitis and pneumonia. They can cause quite significant itch, and of course most importantly is that they can cause dependence. Now when I talk about dependence, I'm going to come on to cancer patients a little bit, but while we're discussing this topic, it's really important that when I discuss with patients who are end of life, sometimes they often find the idea of opioid dependence quite frightening, and it's really important that you flip that on their head. And I have often, I'm quite straightforward with these patients when discussing this matter, to sort of say, actually, well, who cares? You shouldn't be in pain. There's no need for you to be in pain. It's important that whatever time you have left, that you're able to function as best as you can. So take all the drugs that you need if it's going to help you function. And that's quite often a bit of a eureka moment for patients when they realize that actually it's important they are able to function and dependence is not an issue for them. That said, if I was to flip that round and say I had a 35-year-old who had chronic back pain, I'd be very, very reticent about just on increasing their opioids at a continual pace without addressing some of the underlying issues. So toxicity, unfortunately, is a common problem for those of us that work in inner city emergency departments and on the acute take. Classical presentation is of a reduced conscious level, pinpoint pupils, and a reduced respiratory rate. It's important to know if there's been a long lie, so they have rhabdomyolysis or renal failure. This will, of course, prolong the duration of action and reduce clearances. It's worth noting that the antidote is naloxone, but the half-life is short and you may need naloxone infusion. So when history taking, it's really important, and I've said this in numerous tutorials, but I'll say it again, about making sure that you are able to have a free and frank discussion with patients about any recreational drug use, the how, the why, the when. Do they have access to naloxone? For example, it's a project being trialed in Glasgow, and I believe that project has been very successful. You want to be able to ask about when, how much they use, purity, and so on. All of those things, although can be quite difficult, it's important that, again, you say to the patient that this isn't about judgment. It's no judge, judge, judge. It's about making sure that you understand the possible toxicology of what they've done and how you can help prevent them in the future. So again, I've put up that picture to make you think about the important aspects of that are not just medical, about when it comes to dependence, about patients' psychosocial backgrounds, history of trauma, abuse, alcohol, codependencies, and so on and so on. It's important also that you feel confident to signpost them to drug and alcohol services, make sure their injection technique is safe and that they are, where possible, taking as much care of themselves as they can. And actually, us in acute medicine, we play a pivotal role in trying to support these patients. So when assessing toxicology patients, and obviously our focus today is on opioids and analgesics, remember it's important to use the ABCDE assessment. It's unlikely that the patient will either be not breathing or will have an extremely low respiratory rate, and they are of course at risk of type 2 respiratory failure and hypoxia. So they may need bag valve mask ventilation, as you can see in this picture. If the naloxone doesn't work, it may well be that they need intubation and ventilation until the naloxone can be cleared. Although usually naloxone given at appropriate doses and rapidly will usually negate that need, but they may need supported breaths either by paramedics on the way to hospital or in the initial phases of assessment in the emergency room. So this is naloxone here. So the initial adult dose is 400 micrograms or 0.04 milligrams. This can be given in a number of ways, preferably IV if possible. And as you can see, that there's a fairly rapid up titration of naloxone, but there are a couple of red flags, as you can see, that I've put on this slide. It's really important that when you are dealing with patients who are at the end of their lives, who are receiving chronic opioids, either via patch, for example, which is quite common in patients who are at end of life, that you don't reverse them properly, you don't reverse them fully. As you can imagine, that will cause excruciating pain and will be extremely difficult to re-analgesize the patient. So if you are really having to use naloxone in patients who are palliative, i.e. they're impending respiratory failure, if you don't, I would recommend tiny doses, i.e. 25 to 50 micrograms initially. I have to say, I have seen a palliative care patient reversed by a colleague, and it was one of the most horrific things I've ever seen in my career, and it really breaks down the doctor-patient relationship. So you need to be really careful about what type of patient it is who has had the overdose, what's the kind of surrounding issues, the pre-existing medical problems, and what the intention is when you are giving naloxone. It works very rapidly. Perhaps some of you may have seen the film Trainspotting if you're old like me, and obviously you can see when the heroin wears off, obviously, and then when the patient's in the hospital, you can see the naloxone wakes them up very quickly. That said, a second red flag for you: total reversal in chronic users may cause an acute withdrawal syndrome, and then actually, paradoxically, they get very agitated, they become hypertensive, and they end up having to sedate them with benzodiazepines and antihypertensives. So again, caution is appropriate, but it's important that you do initiate some treatment, so careful titration but rapid titration. So antiemetics, so one of the common problems with opioids or any strong analgesics is the risk of vomiting. And vomiting is a reflex with a sensory afferent pathway to the central nervous system. Nausea and vomiting in acute illness can be caused by stimulation of the GI tract, vomiting center in the brainstem and the vestibular system. Just as a quick good practice point, beware of mechanical obstruction and ileus. So these are often going to be those who have subacute bowel obstruction, malignancy or perforation. They will often be quite subtle and then have sort of bilious or fecalant vomiting. So always make sure that you have assessed your patient's abdomen carefully. Of the different types of antiemetics that you will see in clinical practice, there's metoclopramide, which increases gastrointestinal motility, cyclizine and prochlorperazine, which is a central antihistamine, ondansetron, which is a 5-HT3 receptor antagonist. There's dexamethasone, which is a glucocorticoid, which is reserved for severe nausea and vomiting. So I'm going to show you a couple of prescribing ladders now. So when considering the need for antiemetics in a patient, this starts at metoclopramide, then cyclizine and prochlorperazine, ondansetron, and then to haloperidol, dexamethasone, and lorazepam. Again, like any prescribing that I suggest, obviously it's important that you use your BNF as a reference text, which I suspect by now you've all got downloaded onto your phones. The Analgesia ladder, again starting from left to right, PRN paracetamol, quickly moving on to regular paracetamol and regular non-steroidal, and PRN such as dihydrocodeine. The next level, or level 3, would be regular paracetamol and regular non-steroidal, regular codeine and PRN morphine. And finally, you'd have regular paracetamol and regular non-steroidal, regular opioid, and breakthrough analgesia. So breakthrough analgesia is where you would take, let's say, for example, 5 milligrams of morphine 4 times a day. But let's say the physiotherapist wants to take you for a walk. So that's going to obviously increase your level of pain. Therefore, you want to give them supplemental analgesia for that activity. So you might give them either an extra 2.5 or 5 milligrams of morphine top up, and we describe this as breakthrough analgesia. So if you are prescribing regular opioids, it's important that you consider what breakthrough analgesia the patient might need on a PRN basis. So I just want to focus now on oncology patients. So again, this is the bread and butter of acute medicine, but there are quite important things to think about when dealing with cancer patients. Some of the specifics I'll come on into a moment. So the ladder in principle is all the same, but you'll notice that on this ladder that there are some important differences. And this is something to think about really in all patients, but obviously cancer patients in particular. So spiritual care is important. How is the patient handling their pain? Are they coping? Do they need a referral to psychology to manage their pain, to make sure that they have build up in resilience and so on? Do they need occupational therapy? So for example, do they need modifications around the house or home to reduce pain, painful procedures or activities at home? So for example, do they need specially modified knives and forks? Do they need a footstool? Do they need handrails at home so that they are not having to pull themselves off or push themselves off a toilet, for example? Physiotherapy to cause to increase muscular strength. Do they need cancer surgery? Cancer therapies, of course, which can cause pain in themselves, which I'll come into shortly, and then anaesthetic interventions such as nerve blocks or facet joint spinal injections. So in oncology patients, pain is one of the most common symptoms in cancer patients, and typically the point prevalence of pain is about 80% and above. Now, the majority of pain will come from direct cancer effects. So this is where the cancer tissue will press on localized tissues or cause invasion, causing localized pain effects. Other possible sources are visceral, so peritoneal deposits and metastases. So, for example, as seen in metastatic ovarian cancer, where the patient will get seeding of the peritoneum and what we describe as peritoneal caking. This often causes a very visceral pain, as basically the peritoneum loses its flexibility, and basically the patient's abdomen becomes a bit like a rigid box, which of course as the patient moves will cause significant visceral discomfort and pain. You may have pain from bony infiltration, so metastatic prostate cancer, nerve compression, soft tissue pressure, so localized breast pain, for example, lymphadenopathy, and so on. Muscle spasm, lymphedema, or raised intracranial pressure in those who have space-occupying lesions. You may get pain from post-surgical complications, so wound infections, granulation, so on, side effects of chemotherapy such as neuropathy and infection, side effects of radiotherapy, fibrosis and mucositis, which unfortunately, as I've seen in some of my patients, is extraordinarily painful. Imagine having multiple mouth ulcers in your mouth and down your throat, as you can, just the thought of it makes you twinge a little bit. Obviously, these are what our chemo patients go through. They may also have pressure sores if they're frail, arthropathy, muscle spasms, and of course, and not to be downgraded in any way, fear and anxiety. So one of my final slides today is the assessment of pain. So you want to take a good and thorough clinical history, the number and sites of pain, pressure points and so on, what's the intensity, radiation, duration, and aggravating and relieving factors. What is the patient's analgesia history? Either try and take it from the patient, ring the GP, ask for a fax, or most GPs are now on summary care record, which can be really useful. Ask how have they been titrating their analgesics. Again, family history can be quite useful. When I say family, as in asking the relatives or next of kin how much they've been using. You'll find in clinical practice that what the relatives describe as the patient's total analgesic intake and what the patient describes are often relatively different. What's a side effect profile? Have they stopped, for example, taking their morphine, for example, because of constipation, a relatively common complication of opioids, and sort of stopped it, and therefore their pain has increased? What is the effect of pain on their activities of daily living? Examine the patient. Do they have arthropathy because they have a knee effusion, for example, which will need treatment with drainage and injection of intra-articular steroids? Think about any investigations that are necessary. Review the investigations that the patient's had, any recent MRI, CT staging, or bone scan, for example. You want to make sure that if you are discharging the patient and whilst in hospital, there's a frequent review and titration of prescribed analgesia. And again, as always, assess the psychological factors as discussed in a previous slide, and signpost, for example, to the acute pain team, the palliative care team, hospice. Certainly, as far as pain goes, there are lots and lots of people that can help you, everyone from the ward pharmacist to the palliative care team and the on-call hospice hotline and so on. So you should never ever be struggling to manage a patient's pain. Certainly the psychological aspects of the patient's pain can be difficult to manage, but certainly you should be able to get advice 24 hours a day. So reference texts today are Training in Medicine, editors Jolly Fry and Chowdhury, CKS guidelines on palliative care, nausea and vomiting, the Essential Guide to Acute Care, editors Cooper, Forrest and Cramp, I have to say one of my personal favourites, the Oxford Handbook of Acute Medicine by Ram Raka and Moore, and Training Anaesthesia by Spores and Kiff. Thank you very much for listening. Don't forget to like, comment, share, and or subscribe. I will look forward to doing another tutorial for you in the next few weeks. I'm going back to my COVID duties at the end of this week, so I'm going to have a small break in between. I wish you all the very best. Take care, everybody, and look forward to seeing you and giving another tutorial again soon.